session, and I'm Dr. Smita Narayanan. And so I shall be calling, I hope you can hear me. Uh, I shall be calling in the order that has been provided to me. First is Dr. Swapnil Modak. Is Dr. Swapnil here? No. So I think we can wait. Dr. Shilpi Kumari. Dr. Shilpi Kumari. Okay, we'll come to the third presenter, Dr. Kanishk Khare. Okay. Dr. Kanishk Khare. Next, I call upon Dr. Shreya. Dr. Shreya? No. Avitesh Kumar? Dr. Avitesh Kumar? That's terrific. Dr. Sayali Shaha? Please do. Dr. Sayali will be presenting on infections after Descemet stripping automated endothelial keratoplasty.
Good morning, everybody. I'll be presenting infections after Descemet stripping automated endothelial keratoplasty surgery. So we had a 77-year-old diabetic male who had a long-standing pseudophakic bullous keratopathy with peripheral corneal vascularization with scar and inferior pannus, for which he underwent right eye desec. Cornea was clear and compact for 3 months post-surgery, after which he developed a sudden inferior corneal epithelial defect along with infiltrate, which we suspected to be infective keratitis or inferior corneal epithelial healing issues. Slit lamp examination showed a geographical ulcer pattern which stained with fluorescein with underlying stromal infiltrate. We diagnosed it as herpetic epithelial stromal keratitis and treated with oral acyclovir, to which he responded completely and developed a compact cornea with clear central visual axis. We maintained him on oral acyclovir prophylaxis and topical steroids. However, 6 months later, he presented with right eye diffuse microcystic corneal edema, Descemet's folds, and mild stromal edema. This suggested of graft rejection, which subsequently failed despite treatment. So this was the presentation. He presented with central corneal ulcer with mild and peripheral stromal corneal infiltrate along with hypopyon, and corneal scraping revealed gram-positive cocci. We treated with topical oral, topical levofloxacin and cycloplegics and steroids, which were discontinued. It healed with central full thickness corneal scar. So discussing about post-keratoplasty infectious keratitis, incidence in developing countries is about 9 to 11%, occurs in all age groups with a high recurrence rate when done for infectious keratitis. Risk factors include topical steroid use, suture-related problems, ocular surface diseases, and previous corneal infections. Complications are devastating, leading to graft rejection or failure, endophthalmitis. Topical steroids in such cases is a double-edged sword. Bacteria commonly are gram-positive, about 82%. Gram-negative are also there. These are generally ocular surface commensals such as Staph aureus, Strep pneumoniae, Staph epidermidis, treated with broad spectrum antibiotics initially and specific depending on culture sensitivity. Lenticule associated infections are generally due to donor tissue, which are difficult to treat and may need repeat keratoplasties. Fungal infections generally commonly are candida, others include fusarium, aspergillus, and cryptococcus. These develop insidiously, and culture of donor rim is essential so that we can treat the infections before clinical presentations. Viruses are less than 7%. Herpes simplex keratitis is the commonest. It shows classical dendritic keratitis, geographical ulcer as in our case, and a non-healing epithelial defect. There is a high seropositive rate within population, which may develop despite no previous diagnosis as in our case. Others include CMV, cytomegaloviruses, and less common etiologies are acanthamoeba, non-tuberculous mycobacterium. So in conclusion, we need to have a high index of suspicion. Preoperative assessment, peri and postoperative care should be optimized, and ocular surface health is optimization is essential prior to planning these surgeries. Outcome depends on the health of the graft, as graft failure increases due to rejection since steroids are discontinued during active infection, corneal scarring after resolution of infection, and recurrences in herpetic infections. These are my references. Thank you.
That was a good presentation. What was the reason you did the keratoplasty for this patient?
Ma'am, he developed a pseudophakic bullous keratopathy post his cataract surgery, which was long standing, and therefore we planned
That
for
was long standing.
Yes.
So because viral keratitis, especially herpetic, are known to recur in the grafts also.
He did not have any prior history of
not have.
herpetic, ma'am.
Okay, that's good. Good presentation.
Thank you.
The next presenter is Dr. Sheetal Nannavare. Next is Dr. Sheetal Kadam. Dr. Sheetal will be presenting on correction of pre-existing astigmatism, effect of OCCI combined with astigmatic keratotomy.
Good morning everyone. I'll be presenting a poster regarding correction of pre-existing astigmatism during phaco and the effects of combined OCCI with astigmatic keratotomy. Opposite clear corneal incision and astigmatic keratotomy with sutureless clear corneal incision in phaco technique have become standard options in cataract surgery to reduce preoperative and postoperative induced astigmatism. This study is designed to evaluate the effect of OCCI combined with AK in correcting PA in phaco over the regular clear corneal incision. Over the years, cataracts incisions have been recognized to influence astigmatism, and with the proper measurements, they can be used to restore refractive error in most accurate way. We present an easy and simple method which can be practiced by any ophthalmologist without the need of any advanced technology or expense. Astigmatism is a refractive error caused by imperfection of corneal curvature, causing rays of light entering the eye to form focal lines instead of focal point, resulting in near and far visual impairment. Steepness of meridian is diagnosed using keratometry. There are mainly two kinds of astigmatism: against the rule, in which there is vertical flattening, and with the rule, where there is vertical steepening. This study design is interventional prospective study. We analyzed 40 cataract patients undergoing OCCI with AK, and there are 35 patients in control group with a 12 o'clock routine clear corneal incision. Inclusion criteria is pre-existing astigmatism more than 2 diopter, and we have excluded the patients having corneal pathology, glaucomatous optic atrophy, retinopathy, and traumatic cataract. We have collected that data at around 6 weeks and 4 months post-op. There is statistical evaluation of outcomes. There is a detailed history. We have taken detailed history of gender, age, ocular surgery, or trauma, or any chronic disease. There is ocular examination involving uncorrected visual acuity, BCVA, IOP measurement, fundoscopy, slit lamp examination, pentacam-based astigmatism measurement, and we have taken informed consent of all involved patients. Surgical technique, clear corneal incision is taken at 12 o'clock, which causes flattening effect on cornea, and it induces astigmatism around 0.5 diopter against the rule, and this is factored in calculations. And the correction of astigmatism, it depends on length, width, and site of incision. Astigmatic keratotomy involves performing transfer cuts in arcuate or straight fashion perpendicular to steep meridian of astigmatism at mid-corneal periphery. In this, 600 micron guided blade was used, and deeper and longer incisions produce greater effect. In OCCI, it consists of 2.8 mm stab clear corneal incision, similar to the main one, on steep axis. Paired OCCI both 180 degrees apart on steep axis is a useful technique to correct mild to moderate pre-existing astigmatism. Patients are followed up on day 1, 7, 4 weeks, 6 weeks, and 4 months. And we have analyzed that mean astigmatic correction was 1.8 diopter in OCCI plus AK group, but there was only 0.4 diopter correction in control group. No complication related to OCCI or AK or cataract surgery occurred during the follow-up period. AK combined with OCCI are safe, cheap, simple, and easy to incorporate procedures by any ophthalmologist. This can be used for similar results in other procedures also. These are my references. Thank you.
Your results showed that mean astigmatic correction was, take the previous slide please, 1.8 diopters in the OCCI group
OCCI plus AK.
plus AK.
Yes.
And in the control group where you did not
Point
do anything, it
no,
was only 0.4 diopters.
Yes.
That itself is a very small
Yes,
need. So, why do you prefer a superior incision, or did you do that only for this kind of this
Only
study?
for this study. Yeah.
study, and you did not prefer a temporal
No.
incision?
Thank you.
The next speaker is Dr. Maxwell Silva. The next speaker is Dr. Shalu Byadwal. Dr. Shalu shall be speaking on magical effects of glycerine used per-operatively to enhance visualization in cases of corneal edema.
Good morning, respected judge and my dear fellows. I am Dr. Shalu Byadwal, presenting magical effects of glycerin used per-operatively to enhance visualization in cases of corneal edema. As we all know, transparency of cornea is one of the necessity for crystal clear vision. Patients mostly complain of blurred vision, eye discomfort, and photophobia. Now let's talk about the star of the show, glycerol, which is also known as glycerin. It is a simple, colorless, odorless, viscous liquid that is sweet tasting and non-toxic. It is regarded one of the most effective humectant and can be used as an ophthalmic demulcent, lubricating the eyes, mucous membrane, and surface. I studied a series of 8 cases with corneal edema such as corneal decompensation, acute congestive glaucoma, and raised intraocular pressure. It is difficult to operate in such patients with as microscopic view through cornea is hazy. In the past, glycerin was used per-operatively to almost instantly decrease corneal edema, but with the time, use of glycerin has dwindled. Under all our septic precaution, we have to put 1 drop of eye drop proparacaine for anesthetic effect, and to maintain sterility per-operatively, we have to put 1 drop of povidone iodine before and after application of glycerin. Then we have to apply 1 to 2 drops of commercially available glycerin to the cornea, and then we have to wash it off. And instantly it provides better visualization during the surgery. Here are some examples showing the effect pre and post application of glycerin. This is a 45-year-old male with haptic and AC and corneal edema. This is a case of corneal decompensation. In post application, we can appreciate that corneal edema significantly reduced, leaving the scarring behind. This is a case of 65-year-old male with lens-induced glaucoma. 8 out of 8 eyes with epithelium corneal edema showed considerable regression of corneal edema, providing clear vision and better visualization during surgery. Glycerin reduces corneal edema like magic, as it is hygroscopic in nature and absorbs water. Topical glycerin is a simple, effective modality that can be used intraoperatively with huge impact. 1 glycerin bottle of 45 rupees can be used for more than 100 of patients. Topical glycerin is a simple, cheap, non-toxic, easily available and effective modality to decrease corneal edema. We can use glycerin for cases with corneal edema per-operatively to increase visibility during surgery, which will last till the end of the surgery. Thank you.
I just want to know, how did you sterilize that glycerin?
Ma'am, per-operatively, as we are using commercially available glycerin, so we applied eye drop povidone iodine. And in journal, we can sterilize glycerin by autoclave and membrane filtration.
That would have been better if you had done that.
Yes, ma'am.
It's okay, thank you.
Thank you, ma'am.
Do you use Hypersol eye drops?
Yes, ma'am. Ma'am, but
Is there a difference between that and glycerin?
ma'am, Hypersol needs some time to act.
Yes.
While glycerin just we applied and washed with normal saline, it significantly reduced, and it more
You
effective.
say it is faster and
Huh.
more effective.
Yes, ma'am.
Okay.
Thank you, ma'am.
And so now we come to the last presentation. Dr. Pranita Matani. Okay. So most of the presenters are not here. Thank you. I think if there is anybody who wants to ask any questions. Okay, I think I declare this session closed.